Hey everyone, welcome to another episode of Heroes of Healthcare. I'm your host, Tim Fisher. This podcast shines a light on people in healthcare who are making a positive difference in the world. By any definition of the word, they are heroes. Today we're excited to have Dr. Sally Brooks on the show. Dr. Brooks has 30 years of experience in developing and implementing person-centered, high-quality, and cost-effective healthcare programs. Why would a physician move from clinical practice to working for an insurance company? How important is the relationship between patients and physicians? Listen in to find out. Thank you so much for joining us, Sally.
Well, thank you for the opportunity to be part of this wonderful event.
Absolutely. So Heroes of Healthcare, we have this to kind of put a spotlight on heroes who are in healthcare. But before we get to your journey, I'd like to start with, can you share with our listeners just where you were born and raised and kind of how your childhood was? And I'll get to the why behind that later.
Okay, great. Well, I was born in a small town in Ohio, and I've moved to many small towns in Ohio because my father was in agriculture. And so we moved to a lot of small towns so he could be the county extension agent. So I'm really rural. But I had great opportunities there. And I had loving parents who just always assumed I would go on for higher education. And so that's how I got into my career.
Was anyone in your family or extended family a physician?
No. In fact, really, I'm the first, apparently, Brooks female to ever be a physician in our lineage line.
All right.
Mom was a dental hygienist. So no doctors.
Okay. So I always find it fascinating if, because sometimes, my dad was a surgeon or my mom was a physician. And I always wanted to be like my parents. But you kind of broke the mold a little bit in your family.
Yeah, I guess I did.
So you grew up in rural Ohio. And where'd you go to college and how did that work?
Yeah, so I went to pharmacy school first at a small school called Ohio Northern University in Ada, Ohio. And I, coming from a small town, even though I did well in school, I thought, wow, pharmacy school is, the height of what, I'll be able to accomplish. And then I got to pharmacy school and I actually did pretty well. And realized what I really liked was the person-to-person engagement. So I decided to go on to medical school.
So you made the decision to be a physician when you were in pharmacy school?
That's correct.
Okay. And then walk us through your journey once you decided to be a physician.
Yes. So, I went to another Ohio rural medical school. I finished up at a similar school in another state for personal reasons. And, all through that time, I always felt myself drawn to older adults. It was always sort of my calling and had a mentor in medical school who encouraged that. So after finishing internal medicine, I completed a geriatric fellowship here in Cincinnati.
Okay. And then you started in clinical practice, obviously. Mm-hmm. And yeah. when you first started, were you fulfilled? Did it meet your expectations for everything that you worked hard to attain?
Yes, I would say it did, and then some. So at the time here in Cincinnati, I was only one of two geriatricians. And so immediately, the hospital, and this was the hospital where I did my residency, asked me to start some senior programs, education for the internal medicine residents. So I quickly went to both a clinical and an administrative role.
Okay. So obviously, I mean, in a city like Cincinnati, to only have two physicians specializing in geriatrics is kind of very telling, I guess, is the way to put it, because as you know, there's a physician shortage around the U.S., but for a city the size, that's not rural. I mean, Cincinnati's has quite a few people compared to the places where you and I grew up. Maybe it's not New York City, but not an overabundance of physicians specializing in geriatrics. So
That's right.
that also says that there's probably areas around the U.S. where there's not much of a focus on that, right?
Correct, correct. And so that was back in the early 90s, and there's been a lot of growth in the field. You'll see organizations like the American Geriatric Society enroll more and more members. But the reality is, a lot of geriatrics is being provided by internal medicine and family medicine physicians, and that's fine. They just need support and resources from geriatricians to help them do that better. But you're right, geriatrics isn't necessarily what we call a sexy field. People aren't necessarily flocking to it. And what I've found, it's people have a calling for it.
Mm. What did you love about that when you were doing that full time?
I love the people. And quite frankly, I love learning about people's history. And so if you're taking care of a 95-year-old, they're going to tell you something that their lifetimes were way before yours. And I like learning the history of it. And I also like being able to help add quality to people's lives, which isn't necessarily quantity. And so that just takes a separate skill set.
Yeah, it's interesting in life. When we're younger, we think we have it all figured out, and we don't listen to people. And then when we get a little older, we realize we didn't have all the answers. And then when you get a lot of wisdom, nobody wants to listen to you.
Well, it's interesting. I guess I'm just an old soul at heart. But by asking those questions, I took care of Ginger Rogers' dance teacher, which was very fun. And so you meet people like that, people in the military that could tell you about their experiences in the wars. So I'm just interested in humans. So it fulfilled the need for me.
That's great. So you were doing clinical practice, also administration, and then what did you do after that?
So I had a life-changing event, Tim. I had twins at what they call advanced maternal age. I think that's their way of making that sound nicer. But we were all totally healthy. I had been working about 60 plus hours a week in a lot of different aspects of geriatrics, from home health, hospice, all the way up to acute care. And I was the medical director at that time for about 8 skilled nursing facilities. So that's fine. You don't have any kids. Worked for me. And then I had twins that were born early, and they had to be fed every 3 hours. So quickly taking the calls from the nursing center and getting back to sleep. And then the 3-month-old is getting up, the newborn's getting up. It just didn't work for me. And so serendipitously, at a charitable event, the woman who was over government programs for a health plan said, "Boy, we need a geriatrician." And she sent me the job description, and I looked at it, and it was part-time. And I thought, you know what? I can't do this part-time, because if my patients are calling, I'm always going there first. So created a full-time position, and I still had my clinical credibility as a preceptor for internal medicine and geriatric fellows. So that was just a window that opened that I didn't expect. And then after that, I think it's just that windows kept opening, and I was realizing that those experiences gave me more tools in my toolbox to be eligible for even more and more roles.
So some of our listeners may not know that, how this works. So you're a physician, you're board certified, you're specializing in geriatrics, and then you go to work for an insurance company. Like what does an insurance company need a physician for?
Yeah, that's a great question. Well, that was right around the time, we call them Medicare Advantage now. Back then they were called Medicare Plus Choice plans, were coming to the forefront. And so a major insurer here was going to, actively enroll a lot of members. The problem was they didn't exactly know how that was going to be different than a younger patient. And so my experience wasn't so much approving or denying services. It was really population health, making sure that the people that created benefits and put forth, like the utilization management team, really understood what does an older adult need and when might denying a service to save money actually harm the patient because they're going to go back into the hospital without it. So it was a more of a higher level position like that. And I thought, I have a lot of people to teach, and a lot of them were the executives around the table.
Very interesting. A lot of people may not know this, but you're not the first physician I've talked to who left practice and went to work for an insurance company. And there's a lot going on in the United States with physicians specifically, because that's who I work with the most, leaving their practice and taking jobs outside of what they went to med school for. So the issue of physician burnout, the administrative burden. A lot of people went to med school to help patients, and they felt like they're getting farther and farther away, and the mental well-being that physicians struggle with. How was that transition for you from a well-being standpoint?
Yes, that's a great question. So I told you that I really needed to do something different because of my family, but I've never felt like going to this administrative role of health plans, or then I went on to providers of services, that I've really far removed from the patient, because what we do is so personal and so one-on-one. I have to know that at the granular level to be able to make better decisions for the higher number of population that we serve. I would say burnout it's a different kind of stress. Having a beeper and being on call, that can be very stressful. However, there's a different kind of stress in professional executive roles. You are meeting deadlines, and you're being stretched across the organization. So that can be disconcerting and burn you out a little bit. But after a while, you do figure how to manage your time, pull in other resources. I can never say that I felt burnout at a job. I'm a pretty optimistic person. But there was one, and I think it was more directly related to my manager.
Mm.
Yeah.
Yeah, it's funny how that works sometimes. So you have a unique lens. I mean, you've since you kind of walked us through your story, and you were practicing and then moved to insurance, and you've moved into CMO roles. You coach physicians, you help physicians, help people. Like, what's your take on the level of burnout or lack of well-being that you see right now in the physician world?
Right. And for clinicians.
Yes.
So the residents that I went to school with that went into practice and stayed in practice, for them, it is sort of this overwhelming administrative burden. They feel like the hands-on touching the patient, really listening for the history, is obstructed by needing to enter the notes at the same time. So many of them have hired scribes, or they have somebody in their office that'll scribe for them. So they're not facing the computer, they're facing the patient. And I know patients don't like that either, because if you're turning around and typing their history, they're like, I'm looking at the back of the head of my physician. So I think the administrative burden is one of them. I will say physicians really need to step up and take leadership roles, because physicians complain about what's being done to them, payment, whatever it is. And I'm like, well, because you're not sitting at the table of decision maker. Like, we need to be in those positions as physicians to help shape futures and lifestyles for other physicians.
One of the things that we talk about is understanding what patients' goals are for their care.
Yeah.
And obviously physicians and the clinicians have a tremendous impact on that. What's your take on that?
My take is that if you took 10 doctors and you said, let's talk about patients that have been in your panel for more than 10 years, they probably wouldn't be able to specifically articulate that patient's goals. And I think taking a thorough history around that is one of the essentials of healthcare. So, for example, a patient that, their family takes them once a week to the river and they fish for catfish, and then that person has a terrible accident, and it looks like the patient, all organ systems are failing, and you need to make some decisions around what are we going to support, what aren't we going to support. And then I would be able to say, at this point, I can tell you your mom's not going to be able to go catfish fishing with you again. That brought her a lot of joy. Let's talk about more palliation and making them comfortable so that you can tie back to what's important to the patient, what really matters to the patient. And I think that helps families too. It's like taking your car to the car dealership and say, you don't go there and say, do everything. You say, if this were your car, specialist, what would you have done with the car if it's starting to break down? So I think it really gives you a way to understand the person, engage their family, and make these better decisions that really are all about quality of life.
Yeah, and a lot of that is kind of the fundamental to that is having some type of a relationship and really knowing the patient, right?
Right.
I mean, I feel, and this isn't always the case, but I feel sometimes when I'm a patient, and that's the thing too, we're all patients at some point.
Yep.
When I'm a patient, many times I feel like I'm a transaction as opposed to, I'm going through the system and we're doing this, but no one's taking the time to understand all those small details and understand what my expectation is. And I understand why. Again, I'm not being critical, but it seems like we've kind of gone away from that.
Yeah. And can I guess you understand why? Because you understand the administrative burden and productivity and all of that.
All the metrics.
Correct. And they have to, make sure those are all taken care of to keep their practice actually getting Medicare payment. I mean, it's that serious. But I think humanizing medicine and really focus on what matters to the patient, if you slow down and do it, what a mentor for me said, 95% of the diagnosis is in the history. Mm. So taking a long history personally, somebody's worried about somebody having a memory problem, pull in their primary caregiver. You're going to learn a lot about the diagnosis just in slowing down with the history. Then, of course, there's medical exam and tests you have to go through, but your patient, for the most part, will tell you what's wrong. But we just have to slow down and listen. And I've always taught students and residents this. When you go see a patient, don't hover over them if they're in a chair or in a bed. Pull a chair up, sit on the side of their bed, and look them in the eye. That takes literally a minute. And it's a whole different, this person cares about me. They're looking at me. They're waiting for what I have to say. It really doesn't take long, but it makes a big impression.
Little things matter, don't they?
Mm-hmm.
The challenge that we're talking about at a high level is hospitals and healthcare systems. It is a business, and there are certain expectations that are put on healthcare providers in general. And what we're describing is trying to not make it feel like a transaction, truly getting to know people, understanding the history, and having better patient outcomes. You've been a clinician. You've been on with an insurance company. Like, how do we solve that problem when there seems to be two different things moving in different directions?
Here's the problem. And I think a lot of other physicians would agree with this. The chasm of trust just keeps getting wider and wider. So health plans have in their mind that these physicians are ordering unnecessary tests. And physicians have in their mind, I'm the doctor, and they're making this really hard for me to be a doctor. And so that the trust chasm just gets further and further apart. There's got to be a breaking point. And that's why I say physicians try to get in places of influence with health plans. You don't necessarily have to be their employee. You could say, hey, I'd like to put my hat in the ring for board position or a focus group for you. Our voices need to be heard. And I think that sounds easy, like narrow the chasm of trust, but I feel like we have to start at picking it away, one by one. And it takes more than one person.
Yeah, if it was an easy solve, we probably would have come up with something by now. And
Right.
there's a dichotomy going on in different ways. And so talk a little bit about the overall issue of how a physician finds. We're talking about healthcare systems, making money and still providing great care to the patients and everybody winning. Talk about physicians and how they can still do what they love, but find balance in their life.
Right. For me, I had to make a change still in healthcare. And, to me, it was going to be a temporary change at the time. And then come back to full-time practice when the girls were older. But what I learned when I made that change, or just incorporating more of the administrative role, is that I had more chance to make a difference than my 400 patient panel. So I think what you need to do is keep practicing. We need good doctors, but carve out time for a role, and you'll be compensated for it, and sometimes compensated for it. And where you have your lips hit somebody's ears that are on more of the control over how these things are run. And I think for me, as I transitioned, I like variety and I love to learn. Like, it really fulfilled that for me.
How much does leadership play into well-being and finding, as a clinician, finding balance in your life?
Right. Well, I've had a 30 plus year experience of transitioning into leadership positions from one to the other. I think that really sticking to basic principles of how you treat other people, you focus on that, and then the other characteristics and quality will come along. So I mentioned trust. That's the number one asset that you have if you're somebody who can gain trust. And people say, oh, well, we've read this business book, it's about being vulnerable, or we've read it, it's about being approachable, or people that are fair, people trust them. You need to figure out for yourself what your superpowers are to be able to gain trust, and that'll take you a long way. Much like we talked about, get to know your patient, get to know the people that are working for you. They all have different motivation. Some are there because they're worried about money. Some are there because they're like quality. Quality is so important to me. And some are there because time makes a big difference. So you're going to see a different work style, and that's okay. You just need to know who's who and how to embrace those. So I think knowing your people, trust, and if you're going to make your own way, it's not like all the jobs that I have had were, oh, we're recruiting for this job. I was in the system and I would see a gap. For example, I was in a large provider post-acute care organization, and one of the divisions was very, very dependent on their medical directors, independent contractor medical directors, to do what they needed to do. And they had no physician leader. And I saw that. I went to my boss, who was the president of the company at the time, and I said, hey, you really need this, and I can do it. An interesting reply. He says, well, actually, you need to go out and talk to that. We had just acquired a company that made that division bigger. you need to go ask that president and their COO. In other words, I need to sell the idea to them. And so what happened with that experience was they kind of shut me down right away. And my first suspicion was cost, because right then I was an allocated cost across all the divisions. And I thought, well, they don't want to pay for me just in their division. But then I started asking a lot of why questions. Why is that? And they said, well, we just don't think we need it. Well, why do you think that when your division is most dependent on these types of medical directors? I kept asking why. I got to the answer. They had had a chief medical officer before who didn't fulfill their expectations, which gave me a window to say, well, what did you expect of them that they didn't deliver? And then I just kept the W questions. If you had this, how would you best leverage it? When would you be ready to go? Who on your team has an interest in this, or you want to give the resource to make this happen? So you're not saying, I need to be the CMO. You're asking the questions, you're drilling down to really understanding and saying, well, we, this company, would really benefit from that. And I have a lot of energy for it. And that's just a whole different way of how you get recruited to positions, create your own job. I had another mentor say to me, well, if you want to do it that bad, just start doing it. And pretty soon people will think it's your job. Mm-hmm. And you know what? I did. And once, because I'd started doing it, I thought, oh my gosh, this is a big need. So it's not always a position profile determined position. You see a need, you see a gap, and willingness to fill it.
Well, there's all kind of data out there, which I'm sure you've seen as well, around healthcare workers and why they're experiencing burnout, and pre-COVID, post-COVID. And for physicians specifically, administrative burden is by far number one. But it always fascinates me that it's not very close. Administrative burden is a clear number one. But down the scale, not very far, is leadership and culture of where a person works. And that probably is not just specific to physicians. Right. The leadership and culture of organizations where any of us work, or where any of us spend time, leadership and culture matters.
It absolutely does. And, Tim, you were in this position like me. We didn't understand that when we were younger in our careers. We didn't understand when you go for an interview, you interview them about their culture.
That's right.
And you ask the people in the halls, they may say, oh, we're going to have a rest break, and, Susie's going to bring some coffee in here. You talk to Susie, and say, what's it like working here? How long have you worked here? And some people say, I've been here my whole career. And I'll say, well, tell me why that is. And then you find out a lot about it. But you're right. I think physicians feel very estranged from CEOs and CFOs because they're probably not singing off the same song sheet. So it's really behooves the physician to get to know those leaders, and for them, the leaders, to see you. And then you'll have a more collaborative relationship. I'm brought back to, it may not be this way anymore, but a VP of medical affairs in a hospital, their job was kind of to sit there and wait till doctor had a complaint or had a need of administration. And they were like the liaison. I think it's physicians have more of a peer relationship, and it's not divisive, like here's the C-suite, here's the physicians. I think it's more collaborative. And frankly, I think if it's not that way culturally, you've made an attempt, you might want to go give your skills to someone else.
Well, it is. I love that story because it is a decision that each of us make on where we work. And there's taking a job, and that you get, you take a job, and sometimes you take a job because it's more money. And, but I go back to what you said earlier in one of your answers to my question. I think if I heard you right, that you have really only been burned out once, and you said it was more because of
My manager.
your manager than it was necessarily the role.
Correct. So it kind of gets back to what are some leadership qualities that people appreciate. I do believe they appreciate firm but fair. I think they do appreciate a leader that will help them kind of go a little off track and discover their creativity, because it may bring back a whole different vantage point. But if it doesn't, and you think, well, they're spinning their wheels a little bit over there, how do you guide them back and not be critical of what they've done? They've learned something. And so you kind of bring them back and you kind of you kind of reestablish the guardrails. But leaders that squash creativity, and you have to do it this way, boy, that'll burn you out, and you're not going to get what you want, for sure.
Very quickly.
Very quickly.
And we've all worked for someone like that.
Mm-hmm. Leaders that do care about you. I mean, I worked for a startup for a year, which is a whole different, very interesting process. But people were genuinely interested in me. I was going back and forth from another state. And how was your weekend? How are you feeling about being here? Is it hard to travel this much? And I thought, boy, these people really care about me, And so I think showing people, no matter what position you're in, that you really do care about them and you want them to succeed. Like that's your goal. And you're there to remove barriers to help them succeed. I think that's what people are really looking for in leaders.
I agree. And I think we need more of that in the world, whether we as parents or as leaders. Mm-hmm. Unfortunately, you can differentiate yourself in this world by truly caring and being genuine and caring about other people.
Right. Because, especially physicians that have really good clinical skills, they know when you're not being authentic. And actually, that whole management issue I was talking about, I left because of my manager. I really didn't feel like I was being authentic because I was quickly shaping myself to the type of person the manager wanted. And I found out that was really demotivating for me. My style isn't perfect, but when I'm myself, I'm more successful.
People want to be seen. They want to be heard. They want to be appreciated. And it doesn't matter if you're a physician who went to med school and people expect physicians to be robots and superhumans, which they're not. We have to care for our caregivers.
Right.
But it's just a fundamental trait that people want is to be appreciated and seen and heard. And I don't think it's specific to healthcare or anything else, but it really fits in nicely to what we're talking about, whether it's physicians or patients.
Or just persons in general.
That's right. Just people.
Just people. Quick little story. Went to the airport for a small trip this weekend. Was going into the ladies' room, and there was the person that, does the service for the ladies' room. I could tell she was working hard. And of course, somebody kind of walks right into her because they're on their cell phone. They don't say, I'm sorry. They just walk by them as if they're invisible. So I had two roads to take. I'm sort of feisty. And the first one was, I'm following that person into the restroom and tell them what they did wrong. And I thought, no, you know what? Why don't you just go back and make that person feel special? And it was a 5-minute conversation. But when I turned to her and I said, hey, look like you're working hard. How's your day going? I mean, her eyes got big as saucers. People don't talk to her like that.
Mm.
And I learned something about her, and I could tell she was really grateful. And I think we should do that everywhere. Usually only takes 3 minutes of your time. People need to be seen and heard.
100%. Very well said. Well, we have talked about a wide variety of issues, and we always end the show with what seems like a simple question, but maybe it's not always simple. So I want to ask you, who is your hero?
It's pretty easy. That would be my grandmother. She had it together. She was so organized that she would have 3 children and 8 grandchildren have all of their Christmas presents wrapped and ready to go at Thanksgiving, and would drop them off. Most of which she made the clothing. And so, first of all, organized, had her act together. But she really didn't have an easy life. In depression, my grandfather was an alcoholic, and she put up with a lot. He lost his job. She started ironing for other people, 4 or 5 jobs because there were 3 kids to raise. And then as he recovered, he actually got a very nice job. And so she got to enjoy that for a little bit. But then she herself became more physically dependent. So much so that she had to quit her secretary in a stockbroking firm job shy of 25 years. That was her goal. And then, complications of getting older. But, this woman was tough. She was tough. And she's really the main reason I went into geriatrics. Mm. I consider her somebody that's really aged successfully despite the limitations, as opposed to when I would do some home visits for pharmacy delivery, you'd see people living in squalor, ignored. And I kind of decided I'm going to do everything I can do to help people age successfully. And so that's why Grandma's my hero. I think she laid the groundwork for there. And she was a Ohio State Buckeye fan. I just had to throw that one in there, Tim.
Of course. Absolutely. We don't want to leave that out for all the people in Michigan, especially, right?
Yeah.
Well, it sounds like she made a tremendous impact on you. And that generation is called the greatest generation for a reason. Mm-hmm. And define toughness that I just admire. And I have a similar story, and it's just a different mindset of that generation. And there's a lot for us to learn from them. So I appreciate you sharing the story that you just shared. We really appreciate your time today, and you have made quite a difference in the world of healthcare, and you've made a difference in a lot of patients' lives. So we want to thank you for everything you're doing as well.
Well, thank you very much. And this was delightful. I hope the viewers enjoyed it. And it would be great to meet the listeners sometime.
Sounds great. Thanks for being on.